Retrosternal Goiter. Here you see a patient with swelling in front of the neck, moving with deglutition, lower border not seen. In such patient, you try to demonstrate the Pemberton sign. Raise the arm overhead until it touches both ears. Maintain the position for a while. You look for congestion of the face and distress. It occurs due to obstruction of the great vessels. Percussion over the manubrium sternum, a dull note will be heard. Here is the X-ray of the soft tissue neck showing soft tissue shadow in the mediastinum. Here you see a CT of the neck and thorax which shows the cervical thyroid extending into the thorax. And here is the mediastinal goiter compressing the trachea. Retrosternal goiter. It can be substernal variety in which the thyroid nodule just displaces substernally, and a plunging variety in which when the intrathoracic pressure increases, the retrosternal goiter comes to the neck, and a purely intrathoracic variety. A goiter can be considered intrathoracic if at least 50% of the thyroid tissue is located intrathoracically. Two varieties are identified. Primary variety in which arises from the ectopic thyroid tissue in the thorax and receive blood supply from the intrathoracic vessel. A secondary variety arises from the downward extension of the cervical thyroid along the facial planes of the neck and receive blood supply from the superior and inferior thyroid vessels. The secondary variety, most common, is extending into the anterior mediastinum, while a second variety, it goes posterior to the trachea, great vessels, recurlaryngeal nerve, or sometimes going into the contralateral neck. Treatment is thyroidectomy. Thyroidectomy can be done by a cervical incision or a midline sternotomy. In most common situations, we do thyroidectomy for retrosternal goiter in cervical incision. But in some occasion where there is an invasive thyroid cancer, where the patient had a previous thyroid surgery and has developed a parasitic mediastinal vessels, or when there is a primary mediastinal goiter, you require a midline sternotomy to remove the entire thyroid tissue.